Thank you for the words. Thank you for the floor, my colleagues. So welcome welcome to the roundtable discussion. It is about viral hepatitis in Africa, and we'll now go into the country experience sharing. We'll have 5 country experiences. The first one from Rwanda, secondly from Egypt, thirdly from Uganda, Senegal, and we close by Cameroon. And each of the speaker will elaborate on four points. The first one is the distribution of viral hepatitis in the country. What are the regional differences? Second point is the prevalence of viral hepatitis. Number three, treatment options. What options do you have in the country to treat hepatitis disease? And lastly, the number 4 is the incidence of liver disease, especially liver cancer, to know what is the situation in the country. Those will be the 4 points elaborated by each of the speakers. So I'm going now to invite the first one, Dr. Sabin Nzasimana from Rwanda. I'm going to introduce him. He's a medical doctor specialized in HIV global management. He holds a master's degree in clinical epidemiology from the University of Rwanda, and is pursuing PhD doctoral research studies in epidemiology at the University of Basel, Switzerland. Also, currently he serves as a director of the National HIV Program for Rwanda and division manager for HIV/AIDS and viral hepatitis at the Institute of HIV Disease Prevention and Control, Rwanda Biomedical Center. For the last 11 years, Dr. Sabin has worked for Rwanda's National HIV Program, gaining senior level experience in HIV program design, strategic planning, implementation, and operational planning research, with a focus on global care and treatment of people living with and affected by HIV. He has served on several HIV guidelines development group panels of the World Health Organization. He is a peer reviewer for scientific journals and has published extensively on HIV in Rwanda. Dr. Sabin is a fellow at the African Scientific Institute and serves as a faculty member for the University of Global Health Equality in Kigali, Rwanda. Dr. Sabin, you have the floor now.
Thank you. Thank you for the kind introduction. I would like to, first of all, thank the organizers of this conference for having all of us together. I'll be very brief on the 3 questions that you asked about hepatitis C, where we are and what is the situation of this disease, and also the different tools we have, medicine, and the cost. As the previous speakers have mentioned, the hepatitis C program in many countries now, it's quite new. I would say the virus itself is not new, but the fight against this virus is quite new. We've actually delayed in many ways to control it. So our program started in 2014, and today we've been focusing mainly on screening more people, and those who are screened are treated, and this is a national program wide, so we don't have specific places where we work. It's actually one program, and we don't have specific key populations. It's more about age categories, the elders having more infections, and the priority of treatment goes in that line. So when we started screening in 2016, January, in 1 year, we were targeting actually to reach 7 million people all across this plan. But first year, we reached 1.5 million people, and wanted to also understand the magnitude of the disease, which was your first question. At that time, the prevalence of hepatitis C was 4%. Across all the data we're collecting in massive screening that we did in 2019, 1.5 million. In 2020, we screened up to 4 million, 2021, 2022. We are remaining actually with 2 million so that we can achieve all the overall target of 7 million we have to screen and treat. So elimination of hepatitis C is achieved. So far, we've treated 80% of all the people we anticipate or we project to have this virus and the need of treatment. So the remaining part, which we plan to be achieved by early next year, we'll have achieved our elimination plan, which was a national priority with all different actors. So this has actually helped us to reduce the prevalence of hepatitis C in Rwanda from 4% that, as I mentioned before, was our baseline, to 1% from our data this year. It's quite interesting how this has been achieved so fast with the collaboration of different partners, and mainly access to medication, as has been alluded to. You need to have a rapid diagnostic test that has great efficacy and also that is affordable. So the one we're using now has a cost of 0.7 cents, and with a viral load of $9, and the treatment, overall treatment of one person up to the cure is around 78 or 79 US dollars, all steps included, including SVR that need to be done after treatment sometime. So this cost reduction from $3,000 before in 2014 to around $60 for treatment, or $78 overall, everything included, has helped us to help our people access to medications quickly with a combination of pre-qualified medications. So firstly, the clatasfil, now we have genotype treatment options. So this was possible because actually we're part of different networks of experts and scientists, but also partners who have helped to invest some resources into this fight against hepatitis C, which is going to be, I would say, achieved soon. We keep sharing these steps. And also having a system that was already dealing with HIV. My colleagues mentioned using HIV infrastructure, personnel, and also experience, because the hepatitis program was linked to HIV programs, which the moderator has mentioned. I've been heading for the last 10 years, but since 2 years ago, I've been given another role. Now I'm Director General of Rwanda Biomedical Center, and I oversee now more than 15 diseases, but HIV and hepatitis remains our focus now. So decentralization is key up to the health centers and community health workers, for now the main in this action of finding those who need to be tested and treated. That's my point, maybe to keep the story short, is to highlight that the strategy was necessary, but access to medication and diagnostics is very, very critical. Decentralization is also important, but also community engagement, because you may have all the tools and people are not coming, and that is not going to be helpful. Then integration and using resources that is actually available in one way or another, not just having an isolated program, has been very helpful. And I want just to thank and Also appreciate our funding organizations that have put in some resources. Appreciate, for example, the Global Fund that was the first organization to allow that some HIV resources or Global Fund resources can be allocated to fight also hepatitis C. And now we're looking into hepatitis B as well. So let me pause here for now, but if there are questions to me, I'll be happy to come back. And thank you so much to all on this call.
Thank you, Dr. Sabin, for this presentation. We can understand that you are now going to the hepatitis elimination target for the next year. We are running to under this, and most of your strong points are the decentralization, the strategy, the access to treatment, integration, and community involvement. Congratulations for this, and we can also understand that Global Funds was one of the partners who helped the country to make easier the access to the treatments. Thank you for this, and I would like to inform public to put on the Q&A the chat all the questions, so Dr. Sabin can be able to prepare all of this and come back to us for the responses. Thank you very much, Dr. Sabin. So I'm going now to the next presentation. It is from Egypt. I'm going to invite my colleague Waid Dos. He's a professor of hepatogastroenterology and endemic medicine at Cairo University. He became the head of the National Hepatology Institute in Cairo from 2006 till 2015. He's the head of the National Committee for the Control of Viral Hepatitis from 2006 till present, till now. Together with his colleagues, he established and supervised one of the most comprehensive hepatitis treatment program worldwide, which has received acclaim from local and international organizations, including the WHO. The Egyptian National Hepatitis C Treatment Program has been responsible for providing treatment for over 1.5 million Egyptian patients with Hep C over the last 3 years, with a cure rate of 96%. This was achieved by establishing 130 treatment centers all over the country, in which patients were treated at the expense of the Ministry of Health. He is a founding member of the gastroenterology endoscopy unit at Kaiser Eilani Hospital in Cairo University, and has special interest in therapeutic endoscopy procedure. He is a member of many organizations. He's a founding member and current vice president of the Egyptian Liver Care Society. Professor Dos has over than 75 publications in international peer-reviewed publications in the field of liver disease, hepatitis, and gastrointestinal endoscopy. Dr. Rashid Waid Dos, you have the floor now.
Thank you so much, and thank you all for sharing this session together. And of course, I thank the organizers for inviting me over. And I'd like to share with you a remarkable success story that of the elimination of hepatitis C in Egypt. Now, Egypt had one of the highest prevalence of hepatitis C in the world. In 2008, a national survey estimated that 1 out of 6 Egyptians had been exposed to hepatitis C, and about 1 out of every 10 Egyptians had chronic HCV viremia. In 2015, we estimated about 7% of Egyptians had active chronic viremia from hepatitis C. Now, the program for hepatitis C elimination was established or started in 2006 with the establishment of the National Committee for Control of Viral Hepatitis, which is a body part of the Ministry of Health, but we are all university professors, including my colleague, Professor Manal Said, and we are all volunteers to help in tackling this huge problem which we had at that time. So our stages for management was as follows. From 2007 to 2014, we treated about 300,000 patients with the treatment available at that time, which was pegylated interferon and ribavirin. From 2014, with the introduction of DAs, we were one of the first countries in the world to give our patients sofosbuvir first, and then other DAs. And from 2014 to 2018, we treated about 2.5 million Egyptians, all the government expenses, in like you mentioned in the introduction, in about 180 centers all over the country, in which only people were treated at the cure rate of 96%. But the biggest achievement started in 2018, when we realized that out of our study, about 2 million Egyptians who are chronically infected with hepatitis C, who were unaware of the infection. Hence the huge survey, presidential survey or campaign, which we started in 2018, to mass screen all Egyptians over the age of 18 years. And consequently, we have screened 60 million Egyptians with the rapid HCV test. And anybody who was positive, we did a RNA testing by PCR, and we were able to identify another 2.5 million Egyptians who had chronically infected with hepatitis C, who were unaware of the infection, and consequently all have been treated. And so in the from 2014 to now, we treated about 4.5 million Egyptians, and we have almost achieved HCV elimination as the WHO will soon grant Egypt a label of HCV elimination. The treatment we used mainly is, like Professor Manal said, and like my colleague from Rwanda said, that we have available in Egypt generic HCV treatments, and the cost per patient per full course of treatment is about $45. This compares, of course, to a price of about $90,000 in Western countries. This will only be able to achieve this by supporting and encouraging generics in Egypt. And now we have about 20 companies in Egypt which produce very high quality generics, and we had them tested before giving mass treatment, and they were just as equally effective as brand treatments. So we were able to, with this low price and with, of course, government support, we were able to treat these millions of Egyptians. As for complications of HCV in Egypt, from the global CAN estimate of 2020, we estimated that about 27,000 new cases of HCC in 2020 in Egypt. Unfortunately, it's the disease with very high mortality. About 26,500 succumbed to their illness. And we know that this disease, HCC, is much more prevalent in males than in females, and in rural areas than in urban areas. And hopefully that with the eventual elimination of hepatitis C and the control of HBV, hepatitis B, with also antiviral treatments, that we very soon will be able to eliminate HCC as well. Thank you, and I hope this is enough for you.
Thank you, Dr. Waid Ross, for this nice presentation. We can see all of your efforts to reduce price. Now we can afford the treatment with $45, and we have 20 companies producing this generic medicine. I think that it is a strong point, and you are now almost at the elimination of SCV and also controlling the HBV. So thank you for your good presentation. Again, I would like to encourage colleagues to ask the question on the chat, so Dr. Boss can follow the questions in the chat and be able at the end to respond to all of them. Thank you very much, Dr. White Boss.
Thank you.
So now I'm going to the next presentation, the next speaker. It is my colleague, Dr. from Uganda, Professor Poshano Okama. I'm going to introduce him. He's a professor of medicine and an academic hepatologist at Makerere University College of Health Sciences in Kampala, Uganda. His major research and interests are the interactions between viral hepatitis and HIV on liver disease and hepatocellular carcinoma in resource-limited settings. He holds a PhD from University of Antwerp, Belgium, under the Prof. Bob Collegunder, following a fellowship in liver disease at the University of Texas, Southwestern Medical Center in Dallas in 2002 with Professor William Lee. In many parts of sub-Saharan Africa, hepatitis B infection is endemic and generalized. HIV epidemics exist. Understanding the consequences of co-infection, including hepatocellular carcinoma, is crucial to inform approaches for targeting screening or secondary prevention with antiviral therapy. In his position, he supervises the clinical services for gastroenterology in Kirundu National Referral Hospital in Kampala, Uganda, and he is immediate past chair of the Department of Internal Medicine. He has published more than 60 manuscripts in peer-reviewed journals with several collaborators, among others with Johns Hopkins University, University of Antwerp, Zurich University of Glasgow. Some of the collaborations related to viral hepatitis in refugee population in Uganda. He has participated in writing the hepatitis B guidelines and revision of hepatitis C guidelines for WHO. He also leads the technical working group for viral hepatitis in the Ministry of Health of Uganda. He teaches and supervises both undergraduate and postgraduate students in the university and involved in the external examinations of various universities across Africa. Professor Poshano, you have the floor now.
Thank you very much, Casimir, my friend, for the kind introduction. And I want to thank the organizers of this meeting for inviting me to share our experience of viral hepatitis in Uganda. I just would like to start by saying we have got quite a bit of experience with viral hepatitis B and some limited experience with viral hepatitis C. consequently, I will talk more about hepatitis B. Uganda is endemic for hepatitis B. We've had two large surveys in 2004. Our serious survey put the national burden of hepatitis B at 10%. In 2016, we had another survey which put this average 4.1%. Now, I should also say at this point that it has been a little bit difficult to actually quantify the morbidity, but that is something that we are working on right now. Having said that, Uganda has had several milestones, and I will mention a few here. One, in 2002, we introduced the pentavalent vaccine for infants given at 6, 10, and 14 weeks. And in 2011, we actually launched the National Health Worker Vaccination against hepatitis B, which was quite successful. But in 2015, because of the high burden of hepatitis B, government took it up and decided to actually release money for viral hepatitis programs, and at that time it was mainly viral hepatitis B, and government released $3 million per year for handling viral hepatitis B in the country. And some of the programs were included, we started nationwide screening of adolescents and adults against for hepatitis B. And to date, we have screened over 5 million adolescents and adults for hepatitis B, and of these 350,000 have been found actually to have infection and linked to care. The other part of the money has been used to set up hepatitis clinics all over in the regional hospitals all over the country so that these patients can be followed up. And we also buy medicine, tenofovir, which is available in free of charge to the patients for those who actually require this money. And this is something that has worked very well. And in fact, every person who has tested hepatitis B positive is screened for viral load using the government funding. And every person with hepatitis B has two times you can be monitored with the viral hepatitis B viral load twice in a year. And this has been something which I think we have taken on as something which has really pushed Uganda very high in terms of trying to handle this hepatitis B. And we are hoping that we are really working through the elimination program of WHO in a manner which I think we are going to be able to achieve it by the year 2030, as has been suggested or planned by WHO. About hepatitis C, really, like I said, we have very little experience, but we have recently performed screening in the blood bank, and we donors who had tested positive in the blood bank. 96 of them had virus, and so now we have a challenge. The drugs are not there, and we are asking our colleagues, Manal and all the others, to help us to provide us with the testing and I mean, especially the PCR, and also treat the population. And we wanted to start basically with those who have already screened positive for hepatitis C in the blood bank. I think that is where I will stop for now. Thank you very much.
Thank you, Professor Oshano, for this Uganda experience. Very interesting to see what are the milestones, and particularly the political and commitments, funding now $3 million each year for hepatitis program. I think that it's very important to showcase to other countries to see that the political commitment can push the hepatitis program in the countries. So also understand that the hepatitis C is not yet enough developed as a response. This is why we are now working on the strategic plan, integrating both hepatitis B and C and others. Thank you for your presentation. So if we have questions, don't hesitate to put those questions in the chat box. And after the last speaker, you will have time for each speaker to give to elaborate some answers to the audience. Thank you very much, Professor Ponchano. Now I'm going to, we are going now to share the Senegal experience with Fatou Fall. Fatou Fall, she's a medical doctor, graduated from University Cheikh Anta Diop de Dakar in 1992, certificate of special studies in hepatology and gastroenterology in Abidjan University in 2002. Professor in hepatology and gastroenterology, École du Val de Grâce at Paris in 2012. Current position, she's the head of the hepatogastroenterology department in the Hôpital Principal de Dakar, member of the Senegalese Society of Gastroenterology and Hepatology, member of the African Society of Hepatology and Gastroenterology, and member of the French Society of Gastroenterology. Fatou Fall, Dr. Fatou Fall, you have the floor now. Thank you.
Merci beaucoup pour cette introduction très courtoise. Donc, le Sénégal, pour ceux qui ne le connaissent pas, est un pays d'Afrique de l'Ouest qui compte aujourd'hui environ 17 millions d'habitants. C'est une zone de forte endémie d'infection virale B. Dans le passé, les études de prévalence ont évalué la prévalence entre 11% et 15%. Mais les études plus récentes ont rapporté des prévalences un peu plus faibles, notamment au Centre national de transfusion de Dakar, qui a conduit une étude récemment, qui a rapporté environ 7,5% chez les donneurs de sang. Donc, c'est chez les donneurs de sang où la prévalence a été le plus étudiée. Il n'y a pas d'études en population générale. Et malheureusement, il n'y a pas également de données régionales, puisque la prise en charge est surtout centralisée dans les grandes zones urbaines, surtout à Dakar. Donc, on ne dispose pas de données dans les régions. Donc, chez les donneurs, Les dernières études ont évalué la prévalence entre 7,5% et 12,5%. La seule étude disponible chez les donneurs a été conduite à Ziguinchor, qui est au sud du Sénégal, où une prévalence de 10,5% a été rapportée. Donc la prise en charge pose un peu problème puisque il n'y a pas vraiment de politique de dépistage en population générale. Donc, ce qui va à l'encontre des directives pour l'élimination de l'hépatite B. Le dépistage systématique est réalisé chez les femmes enceintes et chez les donneurs de sang. Et malheureusement, souvent, ces derniers ne sont pas informés. Et quand ils sont informés, certains ne sont pas adressés dans un centre où une prise en charge peut être mise en place. Donc ça, c'est un gros problème pour éliminer l'hépatite B dans notre pays. Donc, pour ce qui concerne l'hépatite C,
HVC prevalence is also low. Studies for blood donors also show that we have about 0.66% in a national hospital at Dakar and also at the center of Ziguinchor. The studies that we have had show about 0.08%. So that's a very low prevalence. All the studies that are available when it comes to zero prevalence, I talk about very low rates when it comes to HCV. The prevalence has also been studied when amongst drug users, injection drug users, the prevalence rate in Dakar when it comes to zero prevalence is 23.3%. And when we also when we take those who are those injection drug users, we have a rate of prevalence rate which is about 40%. Now, when we take of those who are in prison, prisoners, those who have been tested, the prevalence rate is about that is 0.4%. There is a recent study which has not been published, which when it comes to specialized studies, which was carried out between 2014 to 2019. So the Delta prevalence is about 2.24%. Let me say that there is a publication by the Global Health Center in 2007, which has estimated that the Delta prevalence rate are at 2.7%. So it means that the two studies have the same results. So out of apart from blood donors and the persons who are living with HIV, so we have a prevalence rate of about 17% to those who are living with HIV, but the HCV prevalence is 8.7%, but 3% for Delta prevalence. We know that when it comes to HBV, its prevalence rate is very high, but when it comes to HCV and the Delta virus, prevalence, they are lower. When it comes to care, a lot of progress has been made. The introduction of the vaccination from when it comes to vaccination since 2004, This is a major progress that we have made. But another major progress is the introduction of birth dose since 2016. Every new child, whatever the status of the mother, on the day of birth, you receive a vaccine on the day of birth of HBV, and then after that, there's a follow-up. This is a major progress also, but the major challenges that we are confronted with is for the elimination of HBV is a lack of data. So Senegal has a huge problem of data. There is also the absence of a clear politics test amongst the general population. Equally, the cost of test courses and treatment have been footed by the individual persons. There is no subsidy. So even if the Ministry of Health has put in place certain policies,
and then they also have the opportunity to do interventions, including taking care of the health. The other problem we are facing in eradication the hepatitis is decentralization, because care is centralized in urban areas not to say in Dakar, because there are very few areas outside Dakar that takes care for viral hepatitis. And there is also unavailability for treatment for hepatitis B. And we also having interference in the treatment we give out. For hepatitis C, there is no molecule available yet, and which constitutes a very major problem for therapeutic care for patients. Thank you very much. This is the end of my presentation. Thank you, Professor Fatoufal, for your brilliant presentation.
You can understand that hepatitis is a big problem in Senegal, but you are now facing to some challenges, particularly on the lack of data on hepatitis in the country. Also, you don't have the program mass screening program in general population. Also, the cost for treatments and the no availability of treatment for hepatitis C. Those are all some problems you are facing too. So it is a necessity to strengthen the advocacy in order to organize the mass screening program and global treatment for our population. Thank you very much, Professor Fatoufal, for your presentation, and also sharing with us the challenges you are facing too. Thank you very much. So don't forget, dear colleagues, to put your questions on the chat box. So Professor Fatoufal will be able to see your questions and give some insight at the end of the round table. Now I'm going to the last presentation done by Christian Tzeuton. Tzeuton. Okay, merci beaucoup, professeur. So, Professor Christian is a professor of gastroenterology and hepatology in many medical faculties, including Yaoundé University. Douala University, Bangante University, Université de Montagne, Mariangwabi University, and Cocody University in Abidjan. He's a member of the African Association for the Study of Liver Disease, and he is currently president of the Société Camerounaise de Gastroenterologie. He is also a member of the World Gastro Organization, a task force. Prof. Tzeuton has previously served as the president of the Association francophone de formation continue en hépatogastroentérologie, and was past vice president of the African and Mid East Association of Gastroenterology. Professor, you have the floor to share the Cameroon experience. Thank you very much.
Okay, thank you very much for this kind introduction, and thanks the organizers to invite me to say words about the situation of hepatitis in Cameroon. You all know that hepatitis is also endemic in Cameroon. We have a national program of elimination of hepatitis with Ministry of Health, of course. Regarding the prevalence of hepatitis, we have many studies, and we can summarize that the prevalence of hepatitis B is around 11% in Cameroon, among which the Delta carriers are about 15%. The prevalence of hepatitis C is around 1%. Previously, we had a very high prevalence, but the correction with Institut Pasteur shows that we are very low, around 1%. And also we have many co-infections in our population. For example, co-infection between hepatitis B and HIV is around 15%. So this is another problem to carry on. About the problem is one of our main problems is to try to decentralize the follow and the care about this hepatitis. So we try to sensitize the population and to implement screening programs in all around the country. But actually, the main point of care are the main cities like Yaoundé and Douala, and we are trying to evolve in the rest of the country. And also the main progress we are going to try to do is to implement the first dose of vaccination. I see that Senegal is already there. We are trying to follow that in order to prevent the mother-to-child transmission. As you know, this is the main way of transmission of hepatitis B. And you see the prevalence, our main problem is hepatitis B also in Cameroon. Regarding the treatment options, we still have very few patients under treatment. And this is because of expenses. It's very expensive. We have a tremendous reduction of cost of treatment regarding hepatitis C, but it is still high for our population. Again, so also the cost of the follow-up, the exams, lab tests, the scanners, and ultrasound is still very expensive. So we hope that the Ministry of Health is going to try to reduce this cost. On the field, we have available all the new treatments of hepatitis C, mainly Sopo plus Dacla and Sopo plus Velpa. The cost is still a bit high, around $500 for the 3 months, for the 12 weeks. But previously it was more expensive than that. So this is a progress, and with this cost, we try to put a lot of patients and to heal a lot of patients of hepatitis C. Regarding hepatitis B, we have available at low cost tenofovir. It's easy to find here, And also we have TAF. Since a few months, we have TAF also here in Cameroon, and that can help us to follow all these chronic carriers of hepatitis B. And for those with co-infection hepatitis B and Delta, we still have this regulated interferon. So the main problem is to try to find all the carriers of hepatitis B and hepatitis C and to try to put them under treatment and to follow them. Of course, the main complication elsewhere in the world is the evolution to cirrhosis and to liver cancer. And this is a very big problem in our country because generally of these hepatitis patients go to healers. And so we see them very late, and generally there is when they already have cirrhosis or often liver cancer. Because we know that in Cameroon, when you have the cancer, the responsible is hepatitis B in 65%, so it's very high. Hepatitis C only in 20% of responsibility, alcohol only 8%. It's not like in Europe. Here we have a problem with hepatitis B mainly, and the other causes like metabolic syndrome and alpha-toxin are very, very low responsible in Cameroon. So the main thing is to try to continue to fight against this hepatitis B and hepatitis C, and of course hepatitis D, in order to try to eliminate these two hepatitis in our country and to reach the goals of the World Health Organization. Thank you very much.
Thank you, Professor, for your good presentation, giving us the situation of on hepatitis in Cameroon. But as you can understand that hepatitis is also a big problem in Cameroon, but access to treatment is a big challenge now. And we can see that for just the treatment for HCV for the 3 months, the people have to pay $500, while in the Egypt it is $45. So I think that those are some things we should think about to see how to make possible the accessibility of the treatment in all our continents in the same conditions if possible, and also to mobilize, to continue to mobilize domestic fundings in our country, and at the same time also the partner funding like Global Fund, and as you can see in the Rwanda example. Sorry, we are at the end of our session. The organizer says that we don't have time to respond to all of the questions. So I call all the speakers to give some inputs, the responses in the chat box. So the organizers can collect them to share to all to the audience. Thank you very much for your attention. Thank you thank you to all the speakers. It was a very good session. More information, more informative. So we have learned a lot about the country differences and what can be do in the next time to go through the elimination targets. Thank you very much, and goodbye.